Thank you, Dr. Partiwala and Dr. Narvikar. I'll be speaking on arthroscopic cuff tear evaluation and planning, and this is just one video I'll be going through. So you start your arthroscopy with the posterior portal, and then I quickly make the anterolateral or the mid-lateral portal, but you want to be in the middle of the width of the rotator cuff tear to properly evaluate. Now I look from the middle, and then I have two instruments coming from one left portal, one right portal, and they will help me go ahead with the evaluation. And these are the general tears that you should be aware of. Now there is a U-shaped tear which the apex gone medially, and then there is a V-shaped tear. There are two leaflets to it which need to be reduced. Then there is a anterior L and a posterior L-shaped tear in which you need to reduce the apex and put the anchor where it reduces. Now this is a video I'm looking from the middle, and then there is a V-shaped tear, and I'm trying to reduce and see how it reduces anterior and posterior limb of the tear. And sometimes when you're looking like this, there is a delaminated tear. There is a one lamina as a deep one, and then as a superficial one, and both need to be reduced. The next step, if the tear is not reducing, what I'll do is I'll release the cuff, and it needs to be reduced all deep to the cuff, which are the capsular adhesions, and then it needs to be reduced also above the cuff, which are the subacromial adhesions, which helps you better evaluate and reduce the cuff tear. And then you plan your anchors and put your anchors where the cuff reduces without tension. So this next stage of planning is anchors, and it should reduce without tension. So my starting anchors mostly are near the biceps because I'm doing a tenodesis many times. So one anchor near the biceps, then the thread goes in inside the biceps. I took out a lasso, I form a lasso loop. Then the other limb of the same suture goes again, and this will be utilized to do a biceps tenodesis after cutting the biceps from the supraglenoid tubercle. Now after I've done the biceps tenodesis, this is a double loaded anchor. So one suture is still remaining, which I utilize to suture it to the cuff. I reduce the cuff, I pass these sutures with the help of my clever hooks, and I pass it through the cuff, and I suture it near the first anchor, which is near the biceps. Now if the biceps anchor is possible, good, then I evaluate if I need a second lateral anchor, and if I need a second lateral anchor, that will be more posterior, or if the cuff is more posteriorly placed, then I'll put another lateral anchor, and the cuff should reduce without tension. So the sutures are passed same way. I pass a lasso loop. One limb is as a lasso loop, other one as a non-lasso loop. And because these are all double loaded, which I am using, all the sutures are passing through the cuff. All the sutures will always pass through the cuff. There is no suture, one outside or one inside. Then one is lasso, one is non-lasso with each thread. So if I'll stop if it's a small cuff tear which can be reduced and sutured like this. However, if it's a big tear, then I also plan a medial anchor. And the medial anchor is near the cartilage mostly, or where the deep layer reduces if there is a deep layer. Then the suture is passed through the deep layer. I pass it as a lasso loop again. Then this suture comes out through the superficial layer. The same suture, and the other thread of the other limb will also be passed through the deep layer and the suture and the superficial layer. And this will help me reduce the deep and the superficial layer. So in the end, it has to look like this. If I have a tear, I put one or two or three, as the need may be, lateral anchors, and each lateral anchor has sutures being passed as a lasso loop and non-lasso loop. And there are medial anchors in which the sutures are passed in a mattress manner. So in the end, you have a mattress, deep, a medial layer, and lasso loops at the lateral. So this is what you have to be aware of. Also, very important knowledge that when you are releasing, so you have a margin of 2 centimeters anteriorly near the supraglenoid tubercle. So from the glenoid rim, 2 centimeters is a safe margin for release, and you will be away from the nerves, neurovascular bundle. And at the level of scapular spine, your margin is 1 centimeter. So this is the safe zone, and you can go on releasing 1 centimeter, and you won't hit the neurovascular bundle. Thank you.